going. And then just another 2 minutes from me before I introduce you to some amazing guests. Um, what are we? It was prompted by someone called Alex recently, was sort of wondering what the heck are we? What is life on the level? It's probably easy to tell you what we're not. So we're not a company, we're not a business, we're not a charity. Um, Technically, we're not even an organization in the legal sense of the word. We are, believe it or believe it not, we are you. We are a group of individuals that all share that common challenge. Um, we have no staff, we have no bank account, we have no income, we do no fundraising. We are purely here to try and help and support, bring peace of mind where we can to every member, and try and find the best way for you to learn how to cope and manage and tame this beast that you never wanted, you never invited, but you're living with right now. Um, that's what we do. It's all voluntary. We then rely upon the voluntary time of these great people we've got with us today. And if you can just give a wave for now, but we've got Professor Peter Rea. Hopefully you can see. He does mind me saying this, but in our opinion, the group over the years, he is the best balance expert you will ever find anywhere. And he's also got a very nice approach to patients, which is brilliant, really, really good. We've also today got a short appearance from two people. Claire Thorpe, can you give us a wave? Claire is an audiologist with Royal Preston, and she's going to talk to you about how you can help her to help her hospital improve the way treatment or engagement with balanced patients occurs. And then we've got Dr. Antonio Ruiz, give us a wave. He's going to talk to you very briefly about how you can give your opinions on augmented reality and virtual reality with regards to balanced rehab treatment. And that's all those two wonderful visitors are going to pop up after Peter. I've got one other special person to mention, Wendy Walker. Can you give us a wave, Wendy? Wendy is 40 years ex-NHS senior physiotherapist, and she's now technical director for the Activator Rehab Poles. And we're just going to mention that in the halfway through the meeting, what that's all about. So thankfully, you've heard enough from me. I certainly have. I'm now going to hand over to Professor Peter Rea, who practices in Leicestershire with the Balance Centre and also has a private practice. One thing, Peter, just before you start, and many people ask this of the support group, what do we think of private medicine? We're all for it. We think for the price of a family meal at a nice restaurant, to begin a journey of finding out what's wrong with you and get that peace of mind, if you can afford it, is wonderful. We understand if you can't afford it, how frustrating this is. But the only thing I can say is everyone who does pay takes one more off the NHS list. But this is a personal opinion. Some people are not keen on private medicine, but for me, I just think I know how frustrating my life, my existence was without knowing what was wrong with me, let alone being treated. Um, and it's something you'll hear us say a lot. You have to get the right diagnosis before you can get the right treatment. And as you're about to hear, that's not so simple with balance conditions. So thank you, Professor Rea. If I can hand over to you now, and if you can introduce yourself for those who don't know you, and then dive straight into the presentation, please.
Brilliant. Thank you, Kevin, and welcome to everyone today and anyone who's joining later on Facebook or Zoom or YouTube. My name is Peter Rea. I'm ENT consultant based in Leicester. I've been here just over 21 years. And although I'm an ENT surgeon, I'm primarily an ear surgeon, as you'll see with some of the rather fancy and gory videos later on, and also run one of the biggest balance centres in the UK, where we build up a huge amount of expertise and a fantastic team. So congratulations again to Kevin on the evolution of Life on the Level, which has been a unique and fantastic resource, which itself has grown. And I think Kevin needs a shout out for the huge amount of effort and time he's put in, and for the fantastic group that he's developed. So thank you again for inviting me, Kevin. Now, this year, we're going to look at some slightly more specifics. We had a very general talk last year, which will complement this quite nicely. And I wanted to look at 4 of the very typical conditions that we see in the balance clinic and give you a little bit of background about each of them, and then a few of the newer things that are happening with each of those conditions, some of it from our research in Leicester and some from elsewhere. And you'll also see the overlap between the various conditions. So lots of exciting things. And what you'll see is lots of scary treatments we're going to go through, and lots of interesting surgeries we're going to talk about. So there's lots of excitement, I think, just for later on in the talk. But why are we here? Well, about 1 in 20 of us will experience dizziness related to the ear every year. So in Leicestershire, with a population of about 1 million, that's 50,000 people. We have one of the biggest NHS balance units in the country, but we can only see 7,000 appointments a year there. So we're not even touching it. And we're not allowed to see people from outside the county either in the NHS. And 3 out of 10 of us will see our GP before the age of 65. And it's the commonest reason to see a GP over the age of 75 as well. It's a massive problem. And those of you who are suffering from balance disorder will know the effect on your life. People lose their jobs, retire early, and no one can see the illness, as Kevin has so eloquently described now. So let's set the scene for this afternoon. I want you to understand how I, as a doctor, think about balance. Well, I think there are 2 ways. We have what we call a pathological sieve. So I think about, where is the origin of the disease? And I absolutely reiterate Kevin's statement that it's essential that we find a diagnosis or diagnoses if we're going to have any chance of getting it better. Vertigo is not a diagnosis. Lots and lots of people will come and say, my doctor told me I have vertigo. It's like saying, I have tummy ache. It doesn't tell what the cause of it is. We need to know the cause of the dizziness. And we can separate it into conditions from the inner ear, which is my home, from the brain, I treat quite a lot of that, or from other parts of the body. And if you're interested in dizziness from other parts of the body, there's a talk I did for Life on the Level last October, thinking outside the box, thinking outside the brain box. And you can have a look at that. And that runs through a wide range of additional conditions. Then I think about what your symptoms are. And the really key starting place is to ask, have you got episodic dizziness? In other words, are you having attacks of dizziness? And that goes down 1 line of diagnosis, and we'll get about 90% of our patients diagnosed who present with episodic dizziness. Or have you got a chronic imbalance? In other words, are you unsteady and dizzy much of the time? And I've shown this chart many times in the past, but I think it's quite helpful, actually. And you can Google it. And if you Google my name and Andrew Hugill, you can put up the balance disorder spectrum. And why it's useful is you'll see we divide your symptoms, or I try and divide your symptoms when you see me, into vertigo, which is that sensation of motion, disequilibrium and unsteadiness, and lightheadedness. Oh, I feel I'm going to faint, doctor, that sort of feeling. And then we can divide it into whether it's from the brain and nerves, the blood vessels and heart, the inner ear, or other areas. And there's lots and lots of diagnoses. Do you see? Dozens and dozens of them. This is only some of them we put on here. And some of them have been added on after communication with patients as well. And you can click on a few of these. And we have a very simple description underneath. So that's something, if you're interested in exploring potential causes of dizziness, you're welcome to look at. So today, we're going to concentrate on 4 different conditions. 2 of them arising in the ear and 2 arising in the brain. And the episodic ear conditions are benign positional paroxysmal vertigo and Meniere's disease, and the brain ones, we have an episodic one and a chronic one, vestibular migraine, and then PPPD, persistent postural perceptual dizziness. So these are very topical conditions. And I'm only going to look at them relatively superficially, but I'm going to give you some background on them and some new ideas. So let's look at BPPV. It's sometimes very easy to diagnose. When I lie down in bed, doctor, and roll over, I spin. When I put my washing up, I feel dizzy for 20 seconds. When I put a cup on the top shelf, I feel dizzy. When I go to the dentist or the hairdresser, I spin for a short while. That's BPPV, and it often occurs in clusters. The problem is it's not always like that. Some patients with BPPV can just feel unsteady because they avoid going into the triggering positions. Your risk of getting it in any one year is about 1 in 150. So not a huge number maybe in any one year, but actually on a population basis, that's a really big number. And in any of our lifetimes, it's about 1 in 40. It's probably a lot higher than that, but that's what the publications would suggest. In other words, it's really common. So in an average class at school, at least one person's going to get it sometime in their life. And it gets commoner as you get older. I do have 2 8-year-olds amazing with BPPV, but generally accelerates from the late 20s. And then once you get into 70s, 80s, and 90s, it actually becomes very common. And it often occurs with other balance disorders. Now, I had the great honor of being president of the ear surgeons of the Royal Society of Medicine a year ago, which was a fabulous year lecturing around the country. And while I was researching the talk for my presidency, I came across this wonderful paper from 1952. Now, those of you who have BPPV, and indeed some of you don't, will recognize the name Dix Hallpike. So this is Margaret Dix and Charles Skinner Hallpike, who are London-based ENT surgeons. And in 1952, on the same podium I gave my lecture to a year or 2 ago, they described the symptoms of BPPV. So this is where it first evolved. So we've known about it in a fairly coherent way for about 70 years. And I just love looking back at history and learning from history. And I thought that was a really good starting place for a talk today where really we're looking into the future. And I want to take us to the inner ear. So this is the outer part of your ear canal and your eardrum, the little bones in the middle ear. And then we're going to go into the inner ear, the snail shell of the cochlea, and the labyrinth, which is where there is fluid that tells your brain if you're moving your head side to side, up and down, or tilting, or indeed accelerating. Now, this is a normal, healthy bit of the inner ear. It's called the utricle. It sits just here. And on here are little calcium crystals. We've all got them. They're 6 millionths of a meter across, so you can't see them, but we all have them. But in our patients with BPPV, what Dix and Hallpike called positional nystagmus, they took samples from the inner ear of the patients who had these symptoms, and this whole membrane was destroyed. And so we can look where the BPPV is arising from as being in the inner ear here. And these slides are 70 years old. Let's blow it up now. So this is your inner ear. Do you see the 3 canals, anterior, posterior, and lateral semicircular canal of balance? And there's something called the utricle. So when you're accelerating in your car or going up and down in a lift, the crystals help you know that you're accelerating. Sometimes they break off, and that's what's happening if you have BPPV. And they may float around the canal, and we call that canal lithiasis, or they may stick to this jelly pad called the cupula, and we call that cupular lithiasis. And I'm going to give you a quiz on that just in a moment. I'll be very impressed if anyone gets the answer right to this. Antonia, you need to be looking out to see if you can get this one right. You should. Okay. Now, in 1980, John Epley, he of the Epley maneuver, figured out that actually it was the crystals rolling around in these canals that was causing us dizziness. Look at that, 1980. Do you remember 1980? Everyone listening today, Wendy, I can see you definitely remember 1980. Everyone listening today remembers 1980 because we were all alive then. That's how recently this was understood. Isn't that fascinating? Just in our recent lifetime. And I share this with you because it's really important. You know, we don't know everything. We're still learning, which is why you've got two fabulous colleagues joining us today to ask for help with their research. We're still learning. We're still developing information. We can only know what we know. And if we dive deep in, here it is. Here's your crystal, 6 millionths of a meter across. And it's got a glycoprotein, a sugar and protein core, and calcium laid on the outside of it. It's in the lateral line of a fish or a mouse or a gerbil or you and me. They're all slightly different in different organisms, but we all have them, so they are important. And traditionally, we treat them with the Epley maneuver or Simont maneuver or whatever it is we do. But I wanted to talk about 3 new issues. And I've shown some of this to you before. So this is called the TRV chair. We amazingly have 2 in Leicester, which is pretty greedy because there's not very many of them in the UK. And this is my long-suffering and wonderful audiology manager, Liz, at the infirmary. She's game for absolutely anything. And I shall miss her terribly when she retires. And we can spin you around in all sorts of positions to shift those crystals around and look at the eyes whilst we're shifting you around. And here is Liz again, being rolled around, and a very, very sheepish looking me thinking, I'm not sure I like this idea very much. Anyway, here's some examples of what we see. So look at our patient here. See the eyes are jerking side to side like this. So we call this horizontal. There it goes the other way. Horizontal jerk nystagmus. Tiny torsional element, but primarily it's horizontal. Why am I showing you this? Well, first, it's an amazing picture. But secondly, it means the crystals are in the lateral semicircular canal, because that's the plane of movement. And when you come to see me with BPPV, I look very carefully at your eyes. And people often say, do you see the crystals, doctor? I say, no, I can't see the crystals. But your eyes are a window on your brain. So I look at your eyes, and because I've looked at eyes for years and years and years, multiple thousands of eye movements, I can see what's happening inside the head and the ears by the motion and movement of the eyes. And in this position, if the eyes jerk side to side, that's horizontal canal BPPV. And we treat that with a barbecue maneuver. We roll you over to get the crystals into the right position. This is the common one. Do you see how different this is? The eyes are flicking up. And if you can imagine, just look at this over here. Can you see it's twisting as well? So I know the fast phase is going down to the ground there, and that's called upbeat torsional geotropic nystagmus, which I won't be testing you on, but that's what we call it. And that indicates your crystals are in here, in the right posterior canal. And then if I see that, I'll roll you over and do an Epley maneuver. I have about an 80% chance of getting you better at the first treatment. Or, that's a bit different. Do you see the eyes here are twitching downwards? So that's a downbeat torsional nystagmus. I don't want to get overcomplicated with it, but most commonly that's associated with a rare form of BPPV called anterior canal BPPV. There are other causes, but that's where we see it most commonly. Oh, they're woken up now. And then we lie them on the other side, and actually there you are. See it twitching down again? Magnificent pictures, aren't they? But this is what I see when I look into your eyes in clinic. And I try and work out where the crystals are. Now, with the TRV chair, what's even newer is we've now got data on over 1,000 patients with BPPV and have digitalized it all. And we've become aware that our patients very commonly have multi-canal BPPV. In other words, it's not just in one canal. It can be in up to 3 canals on both sides. So in theory, up to 6 canals. And sometimes it can be free floating. Sometimes it can be stuck to the jelly pad. We call that cupulolithiasis. Or sometimes there can be nothing. So I'm not sure if Kevin's got a prize for this, but is there any super genius listening today who can work out if you have 3 canals on the left and 3 canals, get your pen and paper, 3 canals on the right, and you have 3 different states, normal, canal lithiasis and cupulolithiasis. In theory, it is only in theory, how many varieties of eye movement might I expect to see? So you've got 3 plus 3 plus 3. And the answer, roll of drums, 729. Not bad, eh? Have I seen 729 types of eye movement? Of course I haven't. No, that's far too complicated. But the point of this, slightly interesting, if you're sort of a mathematical nerd, okay, if you like this type of science, is that there's a lot of different causes of BPPV. And you've got to get it right, because if you go and do a home Epley maneuver because you're a bit dizzy and you've seen it on the internet, you can flip it into the wrong canal and make yourself very sick, number one. Second learning point, if you have positional dizziness and no one looks at your eye movements, you very rarely, you might have something bad causing it, a serious disease in the brain causing it. So it's just a little request. Please be very careful to make sure you get someone who knows what they're talking about, looking at your eye movements before you do home Epley maneuvers. Okay, so let's have a think about treatment. Vitamin D, the sunshine vitamin. Now, we've all already seen that these are not rocks in or grains of sand in your ear. These are living bits of you, just like bone is living, with sugar and protein core and a calcium covering. It's a living biological system in your inner ear. And it may not surprise you that because it's like bone, BPPV becomes commoner in those who are more likely to get osteoporosis, so thinning and weakening of the bones. In other words, ladies, and as we get older. Now, of course, it can occur in the young and in men as well. These things are all relative. And interestingly, it's commoner in the winter as well. I think that's really interesting. And there's less sunshine at that time. And probably in the UK, all of us ought to be taking, I'll go back there actually. So all of us ought to be taking vitamin D. Most of us ought to be taking vitamin D over the winter. And there is evidence through lots of studies that taking vitamin D can significantly reduce the risk of relapse of BPPV. So from a BPPV perspective, I think there is adequate evidence to recommend you take it, and it only costs a few pounds a month and you can buy it over the counter. So these are all really good news. And if you have darker skin, you're more likely to get vitamin D deficiency as well. But it occurs very, very commonly in those who have Celtic skin, like me. And of course, for ladies, if you get plenty of sun and you wear a thick foundation with sunblock in it, you're not getting any vitamin D. Just think about that. Now, just a very brief note of caution. Some people probably shouldn't take vitamin D if you've got kidney disease, a rare condition called sarcoid, or you have high calcium in your body organs. So you might want to speak to your doctor before you start it, just to make sure it's safe for you. But it's a cheap and effective method. We get nearly everyone better, but not everybody. So about 1 in 200 people who are referred to me, we don't get better with Epley and Simont maneuvers and so on. So we look at surgery. Here is a head chopped off like an egg in the morning, and we're looking from underneath through the chin into the head. So this is the ear on the outside. This is the lateral canal I showed you in the previous diagram, and this is the posterior canal. So I can approach this by drilling the bone behind the ear, the mastoid bone, and I can plug it off so the crystals don't float around in there. And the first surgery for this was described in about 1990. I think, as far as I can see, I did the first case on both ears on someone about over a decade ago, and they had a very good outcome. We get a few tests done beforehand, and we look at what the cause might be. Very often we don't know. We call that idiopathic. Very often my patients have it in both ears, but just treating one for most people seems to help enough. And then there are other inner ear diseases, and particularly head injury can cause the crystals to keep coming back. Here's the age distribution of patients I've operated on, from late 20s up to late 90s, and generally in the sort of 50s and 60s, but a big age range. And you'll also see that my patients had the symptoms for a very long time before we operated, up to 30 or more years sometimes. But occasionally patients were so distressed by their symptoms, we did go in earlier and generally got very good results as well. So here's the operation. This is my Canadian fellow. I have the pleasure of having an overseas fellow with me every year. This is the ear, this is behind the ear, drilling into it. The ear canal, where you're not allowed to put your cotton bud, is in front of here. And look, here we are, opening up this micro canal and then putting a packing. This is all sped up multiple times, by the way, just in case you feel we actually operate at this speed. And we're putting that in, graft in, then we put bone pate cement on top of it to seal it over. So that's how we plug it. Now it's really tiny, tiny. This is all blown up enormously, but that's kind of the gist of the operation. And then looking at it on a different patient, this is the lateral canal, the ears at the front here. Can you see that tiny tube? There it is. Do you see that tube? That's really exciting, isn't it? That's the inner ear tube, and that's where the little crystals float around. So when I do the ECPLI, I'm trying to get the crystals along here, back into here, into the utricle, and then we pack it all off. So when I got that video, I thought that was a fabulous way to begin to understand BPPV. So we're going to skip on to another disease now, and we talk about Meniere's disease. Now, you've just seen this diagram of the ear, masstoid bone, the posterior canal where the crystals are. Well, this is the brain here. Brain sticks along the edge there. And there's a little sac here called the endolymphatic sac. And then that comes into the ear from close to the brain. In fact, in a small number of people, I've operated on the posterior canal for BPPV and the endolymphatic sac at the same time because they're right next to each other. And here is me accessing this area with an endoscope. And this is the brain underneath this tough tissue. And this is the origin of Meniere's disease, the endolymphatic sac here. So we can even get in there with an endoscope. And we're going to look at a few new ideas with it. This is the definition. I've put in a couple of definition slides, really not for today, but if anyone is watching this on review later on and you wanted a bit more of a sort of academic background. But the key is we have definite Meniere's disease where you have attacks of between 20 minutes and 12 hours, low frequency hearing loss, a humming tinnitus, and fullness in the ear, and no other cause. Sometimes you'll have some of these symptoms. So you might just have fluctuating tinnitus, fluctuating hearing loss, or fluctuating dizziness, and that's much more difficult. And then I can look you in the eye and say, you definitely have probable Meniere's disease. Now that sounds a bit strange, doesn't it? But you see, all I can do is rely on the symptoms, examination, investigations I have in front of me. And sometimes that's not enough to make a definite diagnosis. But we've done quite a lot of research, and I know some of the people listening today have very kindly contributed their data to this study. So we've looked at 411 of our Meniere's patients with definite Meniere's over 4 major UK centres. And we found that about 1 in 5 of you will get Meniere's in the second ear, bilateral disease. That's really important for you to know. And really interestingly from your data, we found that one of the things that made it more likely you'll get it in both ears is a history of psoriasis, which is thought to be an autoimmune condition. So therefore, we have evidence that some Meniere's disease is related to the body attacking itself, autoimmune disease. And that often is particularly sensitive to steroids. Now, many of the other causes of Meniere's are also very sensitive to steroids, but this is particularly so. So this is how we develop our knowledge of diseases over time. And each of us, as a doctor, feels a responsibility to try and put a tiny little bit of information, one more brick in that wall of knowledge we have for each disease. It's much less common than BPPV, about 1 in 1,000 people have this. And all of this data has been published. We've also published looking at subtypes. Because you've very generously provided so much data, we've been trying to work out different groups of Meniere's disease, because it's not just one condition. It's the final presentation, we think, of a number of other conditions. And we found that one group of our Meniere's patients had history of ear infections, and another group, low frequency tinnitus, stress, autoimmune disease, hay fever, and drug allergy. So there were lots of things that seem to relate to it. And this we published only last year. And then there's a paper we're just publishing this year, we're hoping to publish this year. And this is where it gets really interesting. And I think I hope you may be fascinated by this, or you may have worked it out yourself as well already. There's clearly an overlap with migraine and Meniere's from a symptomatic perspective. And that's problematic because Meniere's is an ear condition and migraine is a brain condition. And how can that be? Well, we don't know is the honest answer. And I'm not making any claims for a definite association here. But we've shown that there is enough evidence to say that those with migraine and Meniere's together are a discrete subtype of Meniere's disease. And we're hoping that'll be published sometime this year. And it was a lot of work putting that data together. There is a growing number of publications, which may be speculative, suggesting that migraine causes Meniere's by affecting the blood flow, because migraine is a thing that affects blood flow through the brain. And maybe if the migraine affects the blood flow through the ear, this is what causes the symptoms of Meniere's. Now, this is speculative. I don't know whether it's true or not, but it's where our thoughts are going at the moment. Now, there's something we have now, which is relatively new, which could be really helpful for this. And I'm already using this for some of my patients who present with just fluctuating tinnitus or just fluctuating hearing loss, who traditionally would not be said to have Meniere's disease. Again, if we come back and look at the inner ear, this is the utricle where I showed you the little crystals of BPPV, and this is the cochlea. Now, you saw the bony channel in that video I showed you, and you saw the membrane down the middle. Now, in Meniere's disease, that membrane in the middle swells up. When it swells up, it squashes out this white fluid. So if we do 2 MRI scans, one before putting contrast in and one afterwards, we can see areas where that fluid has been squashed out. So you can see the normal membrane, but there's none here. And that confirms to us that our patient has endolymphatic hydrops. In other words, they have expansion of this fluid channel, and that by definition is Meniere's. So we now have this fabulous way of confirming Meniere's even in difficult to treat patients. And we have a whole range of different treatments we can use. There's a large number. And I'm just going to whiz through a couple. Beta-histine circuit has been the mainstay of treatment. And we have these fabulous research from big study in Europe showing if you take a high dose of beta-histine, your Meniere's attacks reduce. Fantastic. Take a low dose of beta-histine, your Meniere's attacks reduce. Fantastic. It must be brilliant. And if you take a Smartie, your Meniere's attacks also reduce. Slightly problematic. So this is probably not terribly effective for Meniere's. Now, I'm going to accept that some people with Meniere's do seem to find beta-histine very helpful. Maybe that's because there are subtypes who find it helpful. I don't know. But as a doctor scientist, we have to be skeptical and we have to question everything. But one thing we have proven is very successful is intratympanic steroids. And if you want to read the paper, you can just have a look at this. You can plug that into your Google search. We've paid for it to be available for free. It's normally £100 or something, but you can download it for free if you want to read it. And it's a landmark paper, I think it's fair to say. We had published in the Lancet quite some years ago. I saw myself very much as a plumber. I supplied patients. I don't claim to have been the brains behind it, but it was a real privilege being part of this study. And it was funded by you, by patients who have subscribed to the Meniere Society. What an amazing, amazing thing. And I still go around the world lecturing on this. I was in China earlier this year. I was in Vietnam earlier this year. I'm going over to Bahrain, not so distant future. People still want to know about this. And it is fabulous. If you haven't seen this picture before, this is my mother-in-law who has Meniere's disease. And this is my wonderful, wonderful colleague at work who said, he drills people's brains out every day. And he said, Prof, this was the scariest thing I've ever done, injecting your mother-in-law with steroids. But there we are. What were the results? Well, over a large number of patients, we found at 2 years an average 90% reduction in vertigo attacks. Not sure that's happening, sorry. An average 90% reduction in vertigo attacks. What a stunning result. And this, at 5 years, this seemed to be maintained. Some of the patients did need top-up injections. That's fine. But for low-risk outpatient treatment, this has been absolutely sensational. It's really changed so many people's lives. And here you are, number of attacks before, both with steroids and gentamicin, number of attacks afterwards. Just a stunning, stunning reduction. And you can see that the sort of dizziness handicaps, that's here, and lots of other terms of distress are very much improved after treatment. And that's my wife, if you've ever spoken to her on the phone, that's Yanni, that's my mother-in-law. And they forgave us for injecting steroids eventually, so there we are. So are there any other options in Meniere's? Yeah, there are. You've got surgery. Historically, when I was training 20, 25 years ago, I spent a year in Australia doing this, actually, in Sydney, which is wonderful. Endolymphatic sac surgery, drilling out this sac I showed you going to the brain, was the mainstay of treatment. And we said about an average 80% reduction in vertigo with this treatment. There are some papers coming out quoting very high success rates with this surgery. Again, as a doctor scientist, you're always skeptical of individual papers. But I'm beginning to do this again. I'm doing more of it again. And it's relatively straightforward and hearing preserving usually. And one of the new kids on the block is triple canal occlusion. So we've looked at the semicircular canals with BPPV, haven't we? But you can drill into all 3 of them and occlude them. And very high success rates are being quoted for this. I'm a little bit cautious on this one because there must be a reasonable risk of losing all the hearing with this treatment. So it must be a treatment to be used right at the end when nothing else seems to work. So lots of stuff there for Meniere's. Then I want to spend of the remaining 20 minutes Kevin has kindly given me on PPPD, persistent postural perceptual dizziness, because there's lots of really interesting stuff here. I think you'll really enjoy this section. And then I'm going to have a little whiz through vestibular migraine at the end. So we all know that famous picture, and I know I've discussed it with many of you in clinic. The New York, Manhattan, 1930s, 820 feet above the pavement. Just looking at it makes me feel ill. I don't know about you. But if you go and walk along the road and turn around, certainly if I do, I'll be absolutely fine. But if I imagine I was on that beam with an 800, I'm beginning to sweat already, 820 feet above the pavement, I'd get sweaty, I'd get goosebumps, and I would tense myself up like this. And that's what happens often when anxiety becomes part of a balance problem, and when visual dominance, when you begin to use your vision as part of a balance problem. And that's part of the issue with PPPD, because there are lots of inputs to balance, from your ear, peripheral vestibular, your eyes, visual, proprioceptive, sensation in your legs, brain processing, and here's one of the key things, higher conscious experience. And that can overwhelm other bits of balance. And here's a really key concept in balance. When you're walking without thinking about it, you're using the balance reflex in the balance part of your brain. When you think about your balance, because you're scared you're going to fall, you start using the thinking bit of the brain, which is the front of the brain. Your thinking bit of the brain is really smart. That's why you're a human. Trouble is, it's got lots of connections, so it's a bit slower, and you tend to tense up when that's the case. So what are your symptoms of PPPD? Well, I feel I'm on a boat. I feel I'll fall. I might faint. My legs feel like sponge, or I'm floating. And worse in supermarkets, traffic, crowds, patterned floors. I'm very sensitive to motion and light around me. So that sounds straightforward. Except you can feel you're on a boat if you've got a peripheral vestibular disorder. You can feel you'll fall for a whole range of reasons. You might feel you're going to faint because you've got low blood pressure. Your legs might feel spongy because you've lost sensation in them, etc., etc. So do you see the challenge? These symptoms overlap other conditions. Now, please don't read this. This, again, I've put in just in case anyone's watching it on repeat, if you want the scientific background to it. But it has a formal diagnosis or criteria have been made, and you need to have the symptoms most days for more than 3 months, and other conditions need to be excluded. Okay, have a look at this. Anyone recognize where this is? I'll move this out of the way, sorry. So this is the Guggenheim Museum. I thought these were fabulous. These are the crystals of the Otoconia of BPPV. And then you have these sculptures. And you can walk down the sculptures. And I started walking down this, and my body started tilting to one side because my vision was overpowering my inner ear. It was quite an experience. And that's part of the problem in these conditions like BPPV. Have a look at this. How weird is this? Look at these squares. Just concentrate on them. Up, together, sliding past each other, spinning round. But hey, they're not moving. That's an illusion. How weird is that? Bigger, smaller. They're not moving. They're not changing. Your brain is misunderstanding what you're seeing there. And this is a key to understanding many of the balance conditions like BPPV. Have a look at this one. Right. I want you to look at the green and red dot in the middle. What's happening to the yellow dots? They're disappearing. How the heck? I tell you what, they're not disappearing. They're there the whole time. Your brain is focusing on one bit and then losing the input from the other bit. Hang on. What's going on? My brain isn't so perfect. And this was some research. In fact, my son, who's in the other room over there, won best young scientist paper of the year, the British Society of Neuro-otology on. And it's a fabulous bit of research. And I just think that it shows how our conscious perceptions of balance are not quite what we think. And this is a collaboration, as I say, with some of my colleagues and friends. And what we find is patients with vestibular migraine, for example, The worse the migraine, the more sensitive they are to these dots, because the brain is overreacting. Yet in BPPV, it's the opposite. If you have BPPV, you tend to suppress this. So the brain's working in different ways. Now, with PPPD, we think about three principal causes of it. We think about a vestibular event, so lots of people have had BPPV, vestibular neuronitis, some inner ear problem. It's very common in patients who have a history of migraine because they often overrepresent visual information. And it's very common in people who have a history of anxiety. Now, if you have epilepsy or are sensitive to stripes and motion, can you look away on this next one? So we test it in certain ways. This is posturography, which if you come through our centre, you'll probably get. And we can put you into a supermarket. As you see, Liz is breaking all the rules. She hasn't got the harness on. This is long-suffering Liz again. Or you can have stripes and lines, and there's a whole lot of stimuli we can give you. Whoa, or we can have you flying an aeroplane, whatever stimulus it is we want to put you through. And why does it happen? Well, here's Ollie, who wrote that paper. He's now about 6'3" and 15 stone, but this was a while ago on the Inca Trail. How I sat there, I have no idea. I was scared witless there, but the boys seemed to be fine because they had no. We are thousands of feet up here in the Andes near Machu Picchu. Anyway, what happens to me, and I suspect some of you, when we get into these big heights, I stiffen up. I get really scared because I'm very visually dominant and I'm using this frontal processing of balance. I haven't given you a very thorough scientific explanation of PPPD. That's not what today's all about. I just want to give you a sense of how the brain can misinterpret information. But we can treat it. We have to be honest. We're not going to get everyone better. We can't at the moment. But we can help most people with explanations like I've just given you now. With vestibular physiotherapy, balanced physiotherapy is very, very helpful for this. And we're evolving the types of therapy we use. CBT, psychological therapies, can be very helpful for this, to reduce hypervigilance, to change the way the brain thinks about the threat of balance. And medications are also very helpful for many patients with this. And that includes SSRIs, such as citalopram or sertraline, SNRIs, vaccine. And overall, if we put all of these treatments together, we would hope to get about 80% of our patients significantly better. So the final couple of minutes, I just want to whiz through vestibular migraine. Well done for everyone who stayed so far. I hope it's of interest so far. And what you're seeing is there's an overlap between each of these conditions. So let's have a little think about some challenges. We've talked about Meniere's disease already. I've talked a little bit about migraine together with you. But Meniere's and migraine seem to have quite a lot in common. And if you look at my Meniere's patients in clinic, 40% have migraine. 20% also have BPPV. Most will have some imbalance. And everyone has an emotional response. So now do you see, it's not that straightforward. It's not that you've got A, B, C, or D. It's you may have several different conditions together. And that reflects back to Kevin's comment that it's essential to get the diagnoses, because there's often more than one, and then treat each of them individually. Let's think about Meniere's and migraine. You can have vertigo from both of them. 10% of migraine attacks present with vertigo. Don't have to have a headache. 10% of migraine attacks occur without headaches. Fluctuating hearing loss in Meniere's. It's a bit weird. You get a low frequency hearing loss in migraine as well. Not usually severe and not usually very long lasting, but it can happen. The same with tinnitus, although tinnitus tends to be two-sided in migraine and one-sided in Meniere's. Get fullness in your ears. And then in migraine, you often have a range of other symptoms as well. Age of onset isn't that difficult. Isn't that different. Incidences, 1 in 1,000 for Meniere's, 1 in 100 for vestibular migraine. So for every patient I see with Meniere's, I'll see at least 10 with vestibular migraine. Here's some numbers I'm going to throw at you. After BPPV, vestibular migraine is the second commonest cause of dizziness, episodic dizziness. In the migraine clinics, this is neurology clinics, 30 or 40% of patients have episodes of dizziness. In the vertigo clinics that I run, probably a third of patients have migraine. As I've said, it's around 10 times as common as Meniere. So lots of interesting numbers. There's this old concept, basilar migraine. So you just imagine a migraine affecting different bits of the brain. And your symptoms, is it visual aura? Is it headache? Is it tummy pain? Is it knee pain? Is it facial pain? Is it a blocked nose? Is it a red eye? Whatever it is. Those are all migraine symptoms. And it depends on what part of the brain is affected. But some of the symptoms can include vertigo, for sure, speech, problems, tinnitus, sensitivity to loud noise, double vision, abnormal walking, reduced feeling of consciousness, low frequency hearing. Here's a new one, allodynia. One of my colleagues has just published on this. So becoming sensitive to touch on your skin or your hair during attacks, called allodynia, is a common symptom, particularly of vestibular migraine. So that came out only a few months ago. These are the diagnostic criteria, which have only very recently been published. That's another extraordinary thing. Again, I'm not going to bore you with them, but they're there for anyone who is reading this retrospectively. And the Bharani Society have clarified what they think this is. But one of the things about vestibular migraine is it's not just attacks of migraine. It can leave you motion sensitive as well over a longer period of time, a bit like PPPD. So again, there's lots of overlap here. And also note that with vestibular migraine, your dizziness can last seconds to minutes to hours to days. So do you see how difficult that makes it? So just because you're dizzy when you lie down and roll over doesn't mean it's BPPV. You can have this positional dizziness from migraine. I'm always interested to know if you were travel sick as a child, because that's strongly predictive of having adult migraine. A twisted neck, torticollis likewise. Motion intolerance, it's very common in migraineurs. Light and sound sensitivity is key. And if you have your dizzy spells around your periods, it's highly likely to be migraine. And just for the last 2 or 3 minutes, we'll talk about how to manage it. Well, you look for your trigger factors. And the majority of our patients, we will identify a trigger for their migraine. And look, it could be diet, hormones, stress, sleep, drugs, exercise. There's just a whole range of different things. And there's lots of treatments. I'm a great believer in looking for these treatments because you can often get better without the need for drugs. And keeping a diary of everything you do, eat and drink, and relating that to your attacks can be really helpful. And we talk about the 6 C's: caffeine, cheese, Chinese food, Chianti for red wine, but champagne and all the rest of it are also, beer is a good trigger as well, chocolate and citrus fruits. Those are the big 6 C's, but there are a whole bunch of other potential things. And having regular meals, don't skip breakfast, don't skip lunch, poached egg for breakfast, that sort of thing, 2 litres of water a day. Simple lifestyle changes are often critical in keeping migraine at bay. And in Leicester, I was speaking to this gentleman only yesterday. He is the only dizzy gynecologist in the world that I know, but he's a Leicester gynecologist who specializes in hormonal manipulations for patients with dizziness, and he reassures me it's still working. So lots of things that we can do. And there are lots of drugs we can use as well. And we'll get the majority, again, we're not claiming to get everyone better, but we get the great majority of our patients better. Sometimes we have to work through quite a long range of drugs, large range of drugs to get them better, but we can usually manage that. And we certainly start thinking about medication if you're getting more than 2 attacks per month. Most of the work has been done on migraine rather than vestibular migraine, but I'm going to give you some new data on vestibular migraine just right at the end. I like the idea of nutraceuticals. These are termed food supplements rather than drugs, and the classical ones, riboflavin, magnesium, coenzyme Q10. And I think there is adequate evidence to suggest they're beneficial in a number of patients with migraine. And it's quite expensive, this stuff, but you can buy Dolovant. And it's about 40 or 45 pounds a month or something, and it does make your urine go bright yellow, I warn you, but actually that's quite a useful starting place for migraine. So chaps in particular get a bit of a shock with that one. Right, so the broad categories of medicines. Amitriptyline, I'm a great believer in this. It's a tricyclic antidepressant, and nortriptyline. I find these are really, really helpful. The antihypertensives, a lot of the neurologists really like candesartan at the moment. Propranolol we use in some of our younger patients. There are big pros and cons of some of these. For some of our teenagers, we use pazotafen, can have a bit of weight gain. The drugs I mentioned earlier for PPPD, SNRIs and SSRIs, they actually have reasonably good action against migraine sometimes. Topiramate got lots of side effects. And then the new kid on the block, CGRP inhibitors. This is an interesting addition for you here. I was over in Uppsala before Christmas for the Bharani meeting, and it was Bharani who first identified that if you put warm and cool air into your ears, your eyes jerk one way and then jerk the other, and you got the Nobel Prize for Medicine during the First World War for that. So again, another building brick in our wall of understanding of inner ear disorders and brain disorders. So we found at the Bharani meeting that the triptan, sumatriptan, and so on, whilst they help some people with vestibular migraine, they're more headache related and aren't terribly helpful for vestibular migraine. But the CGRP inhibitors can be really helpful. And then there was one big study presented which showed a 70% reduction in vestibular migraine versus a 25% reduction on placebo. So that's pretty useful. And it is a calcitonin gene-related peptide inhibitor. And it affects the blood vessels in the brain in particular. It does some other stuff as well. But that seems to be the origin of a lot of migraine. And there are very, very expensive monoclonal antibodies which can be injected. And they've now developed a group of drugs called GPANTs, which are available as tablets or sprays. And these seem to be good for headaches. And there is evidence emerging that they may also help the dizziness of vestibular migraine. But all drugs, as with all drugs, they do have side effects. Generally, we are looking at people who have 4 or more attacks a month and who have gone through every single other type of drug without success. And often they're prescribed from headache clinics rather than ENT clinics. They need a little bit of monitoring. But these are available to a small group of people. I've not had many people on them, but we are just beginning to use these. The evidence is growing. And as I said right at the outset of this talk, we are learning all the time. So we have to be careful in introducing new treatments until we fully understand what's going on. So there you are. There is a Saturday afternoon skip through where we are and where we're going with PPPV, Meniere's disease, vestibular migraine, and PPPD. I hope there were some little nuggets of useful information for everyone in that. And as always, nice to see you all. I've been looking through your pictures while I've been giving the talk. And we're going to hear from our 2 great scientists now. And then you've given, I understand from Kevin, a list of fabulous questions. And it's my turn then to sit in the mastermind chair and hope I know the answer to some of them. So I'll be back in a minute. Okay.
Peter, if you could stop sharing the screen, please. That's it. That's beautiful. Can I say, just before you take your breather, I don't know how you do it, but you make the most complex, the most easiest to understand of anyone I've ever met. It is such a complex subject area, but every time your presentations just make it so much easier to understand. So thanks on behalf of all the members watching now and in the future for spending so much time to pull this together and then talk us through it. So it really is incredibly helpful. It also, I must say, it's so refreshing to you just say we don't know everything, but we're learning is wonderful. I spent some time over the Atlantic virtually with VIDA, and if new members don't know VIDA, do look at vestibular.org. There they formed an industrial advisory committee, and it's most fascinating with new technology and medications that are going through development. And I'm hoping to bring that experience, the Americans, what is going on now, to the group in the near future. The message to everyone is, as you can see with Peter, there are people here really working so hard on our behalf to find those solutions and treatments that possibly just weren't there. I started my journey 22 years ago. Many things just weren't on the table for treatment then. And Peter spoke of the steroid treatment. I'm one of those that responded very well to that, changed my life. So thank you, Peter, for everything you do. And we're going to come back to you in about 10 minutes with all those testing questions.
I'll go and get a glass of water.
Yes, you can even put your camera off for 5 minutes if you so desire. Okay, everyone, I hope you enjoyed that. Peter just is amazing at what he does. We're now ready for someone else who's amazing, and that is Claire Thorpe, who has been working away as an audiologist at Royal Preston Hospital. You're going to see a lot more of Claire, I hope, because she's agreed to try and work with our group and see what other things we can develop that are going to help and assist people when they need treatment for balance conditions. So I'm going to hand over to Claire to introduce herself and tell us all about her current project where she needs your help. And before you go, we're good for nothing, we've got balance conditions, I can't hold a job down, you are becoming experts by experience in your condition. And believe it or believe it not, while Peter's away making that coffee and he can't hear me, Peter has never had a balance condition as you have. So you know a little bit more than him about some things. So remember that you are an expert and your opinion matters. So Claire, I'm going to shut up and I'm going to hand over to you, and you tell us how we can all help, please. Over to you.
Okay, hi everyone, and I just want to say thank you to Peter as well. Even I'm learning stuff at this point. So we, as audiologists, get trained up in ears first of all, and then we tend to specialise. And my interest is in balance disorders. But in order to qualify, you have to go quite far, do more study. So I'm at a level now where I've been trained to do balance tests. I can read the results of balance tests. But that's where it stops. Our patients then leave that department, and I just don't know what happens to them. I don't know if they're okay. They get an email. Here are some exercises on YouTube. Do them. You can ring us up if you want. You've got a 12-month grace period sort of thing. And I just don't think we're doing enough. So what I want to know from you guys is what experience you've had in sort of getting into the balance sort of system. Was it via your GP? A lot of people come in via A&E, after thinking they've had a stroke. I want to know how you got there, how long it took to get to a diagnosis, and then what help you actually got, if any. So we've not got a questionnaire together yet. I'm happy just to have open emails, just telling me your story. Like I said, Kevin's going to be the point of contact for everything to start with. So, yeah, I feel like I'm sort of waffling on now because I've got nervous. So, really nice to meet you guys. I've watched some of the previous recordings and heard some of the stories. And again, that's why I'm so invested in trying to not just diagnose you, but get you that help. Anyway, nice to meet everyone. Thank you.
Brilliant. Thanks. There's no need to be nervous here.
It's just me. I'm so red now. I'm actually beside myself. And I don't...
Just don't you worry. We love it. We love you. People who want to help our community. This is what we need. And you're in a wonderful position to help with the professional role you've got. So everyone watching this, listening to this, what I'm going to do after the meeting, you get an email with a link to the video anyway. That's when there's going to be a little bit more detail about what Claire's doing. When we're ready, it's probably going to be a survey or questionnaire that comes out to you all, or we may be asking for people to volunteer to take part. We're still working on the actual tactics of it. The important thing is you can help such a wide community there by saying what would work for you, what would help you. And isn't it refreshing? We've got people in the NHS want to hear us. They want to listen to what will work for us. So let's not waste that opportunity. Thanks, Claire. You listening. And by the way, you're going to hear a little bit more from Claire later because she's going to read some of your questions to Professor Rea. So don't go.
Got roped into that one earlier.
Yes. Don't go too. Oh, you get roped into anything and everything here, I assure you. Now we're over to Dr. Antonio Ruiz. I hope I'm pronouncing that correctly, Antonio.
Yeah, it's true. It's okay. Yeah, it's from I'm Spanish, so it's difficult.
Well, you know me
Yeah.
as English, my language skills don't quite extend to English, let alone any other language. Uh, Look, Antonio, I'm going to hand over to you to explain more about what it's all about, who you are. And again, it's please, members, listen carefully because I think we can really help this gentleman and the project is on. Over to you, Antonio.
Thank you. Thank you very much. And also thank you to Professor Peter Rea, because I've also been learning quite a lot today. I've got a couple of slides I'm going to be showing just now, but just as context, what I want today is to show you how, because Kevin said you are all experts, we are the experts, how you can contribute to these research in balance rehabilitation. So I'm sharing my screen. You can all see that. This first slide is about context on who I am, who we are, and why we're doing this. I work for an organization called the Health Innovation Network, which is part of the NHS. We are 15 centres across England, all supporting the private sector, but also research at universities to sort of accelerate research so it reaches patients faster. And the one I work for specifically is the one in South London, which is hosted by Guy's and St Thomas NHS Foundation Trust, which is what you can see on the screen. And today I'm coming because we are supporting a project called Telerehab. If I go to the next slide, there you go. This is an international research project funded by the EU that follows a successful project called the Hollow Balance. We have partners all across Europe, in Greece, Portugal, Germany, Italy, and in the UK is the University College London that is leading the work. Our aim, briefly, is to support the adoption of augmented reality in everyday clinical practice for balance rehabilitation testing. And why are we doing this? Oh, sorry, that jumped. As you probably know, physiotherapy or balance rehabilitation works, but there's a number of problems and issues that comes with it. One of which, for example, is just getting to the clinic, which isn't always easy for all the patients. Our goal is to improve home balance rehabilitation using this augmented reality, which is combined with AI. So you can have a personalized virtual coach that can deliver personalized rehabilitation remotely. This means that people can do the exercises at home. They're guided by this virtual code, but the progress is then monitored by a physiotherapist. The system combines a series of things, augmented reality, smart sensors, so it allows these remote monitoring. And we can hopefully this way as well make the exercises a bit more engaging, more accessible, and better tailored to each person's needs. The system is on research stage. It's undergoing clinical trials, but what we want to do is to make sure these research focus on what matters most, what's most relevant for you. And this is why I am here today. We are inviting people that have history of balance disorders or experiencing balance rehabilitation to take part in a 90-minute online focus group in October. We want to hear more about your perspectives of using virtual reality and augmented reality, as well as challenges, opportunities that this could bring to your field. You won't be asked to try the technology at all. There's not going to be any physical test. You won't need to use any VR sets at all. There was definitely not going to be any physical requirements to join. We just want to present the idea to you in a bit more detail. We'll have the researchers that are working on this on the day, and we'll ask you about your views and discuss your experiences. This focus will be online on Microsoft Teams, and everyone that takes part will be compensated with £30 for the time. Yeah, this is essentially from me. Just to reiterate, what we want to do is to hear from you, your perspectives, your experience, and help make this work as useful and as relevant as possible. thank you very much. And if you've got any questions or you want to contact me after the meeting, it's also okay. But I think, there you go.
That's lovely, Antonio. Thank you ever so much. And again, members, I'll be in touch via email. There's plenty of time before October to get this sorted. Interesting to see you can even earn money from this. I would be doing it for free. So hopefully everyone is going to volunteer for this one. So thanks, Antonio. Thanks for taking the time out today. And we will be in touch soon, hopefully with lots of participants for you. So a couple of minutes on just other things before we get back to these brilliant questions for Peter. I'm just going to, Wendy, if you're there, just right, this is Wendy Walker, who is retired senior physiotherapist with the NHS. Now technical director for activator rehab poles. I have to here declare an interest. I came across the activator poles some 6 years ago in Canada and America and was struck how good they could be for various people with various degrees of imbalance. Not right for everyone. And I still don't know if it was foolish of me or not, but I volunteered to bring the poles over to the UK and Europe. Otherwise, we were never going to be able to access them. Wendy's technical director, and the reason I'm introducing Wendy is I'm going to share her email address on the chat and in the email. And anyone who's interested in the possible use of the activator poles, and I'm just going to try and share screen now that hopefully you can see there. Give you the web address as well. They're not right for everyone, but they are brilliant if you have this imbalance where you're almost worried you're going to fall over, you're losing confidence to walk, and you may be using a walking stick, and you'll find out all sorts of reasons. I won't go into today about why the poles and this technique, hopefully you can see on your screen, could be an answer for you. However, bizarrely, I don't want you to go to the website because, and hopefully this will switch. Wendy, can you nod can you now see oh, wrong. Let's try the right one for you. On the Life on the Level website, we have the foundation. And what I love about the foundation, as much as we've already said, we advocate private medication if you can afford it. One of the best things we do as a support group is support those who have no money at all. They may be on PIP benefits, they've lost their income, and financially things are really hard. The foundation, quite simply, is where we provide products for free, and the only thing we ask you to do is verify that you're already on some form of government benefit, and then that's how you qualify if we have these products. The other good news, I'll come back to the Vida in a minute. So, for example, if you were on PIP benefits and think the poles could help you, you need to click on a link on the foundation page and contact myself, and we can look at supplying these for free. Same with something called the balance belt, which is something you wear that helps you to learn to balance again, but is for only certain types of balance conditions. The reason all of you have seen the foundation page is there are links on here to look at buying these products. You would qualify for a 10% discount on the standard price, and you will also, if you were to buy anything, you would generate a 10% of your order cost donation will go from that company to Vida to help Vida do the wonderful work they do. And do visit their site if you've not been there. So again, all this, I'll put it on the chat today. It's going to go on to the emails that you receive later. And it's just, again, what we're trying to do as a support group is just do anything and everything we can to help you. But we need your help on the feedback, on what's working, what isn't working, what you want from the group, etc. One last thing to share, and this really is for the benefit of the new members. Let me get the right page. Hopefully you've seen today the beginnings of what we do as a group, and it is all about you. The one thing I can't recommend enough to you is the member-to-member contact network. All it is, you can only join if you're already a member of this support group. And it's why we ask to verify addresses, by the way, because the member-to-member network, we're going to put you into a list where you've opted in to share your email with all other members who've also opted in. Christian name, email address, nearest town or city you live to, and your balance condition are on that list. There's over 100 members already in there. The beauty of it is you can reach out at any time. Some people provide phone numbers as well for phone, WhatsApp, texting, and make new friends. And these are going to be unlike any other friends you've ever had, because they're never going to go, are you sure it's in your head? You look so well, don't understand what you mean, because they are living your life. Strangely, even though you'll see the conditions, and I know you're going to be drawn to people with the same condition as you, that's an obvious one, but I encourage you to reach out to all others as well, because you'll be amazed. As much as Professor Rea has said, and completely agree, diagnosis is essential and vital. Beyond that, as a person, most of the challenges you are going through with your balance disorder are so common throughout all of balance conditions. The fundamentals of being isolated, the fundamental of no longer socializing as you used to, and people saying, what's wrong with you? You never go to these parties anymore. The threat of losing your job, all these things, you can have these people who've been there, done it, wear the t-shirt, and can be chatting with you. So I encourage you, when you can, link it to the page over there. All you've got to do is email me again, but with certain details. And the next list, make a note, next list is coming at the end of this month. So opt in the next couple of weeks, be on that list, meet new people. It's the best thing you'll ever do. Remember, we only meet 6 times a year, but with all these new friends, you can be chatting every week. We even have members where they found they're geographically close and they move to then meet together. And again, beautiful, beautiful friendships with people who just totally understand. That's almost it. One last thing, support group. We're here to support you. Members will go through various stages at various times, and we've all been there and had the black days, the bleak days. We're here for that. Contact, email me. We do what we can to support and help. Sometimes just chatting to a complete stranger like me can be a great thing to do. And sometimes we come up with ways forward, ideas you may not have thought of. So don't hesitate to reach out. You've all got a list of balance buddies as well. So let's just do everything we can. The solution, as much as we got the experts with us today, I strongly, totally believe part of the solution lies within you all as individuals. It's discovering the way to emerge from this condition. There's only so much Professor Rea can do medically. The rest of it's down to us on how we approach things and how we can control our response to all these weird inputs and strange things going on in our life. More of that later with the group. You'll see what we do to cope with anxiety, etc. Right, Wendy, I'm gonna unpin you from there and put your email up later. And do email Wendy if you've got any questions about why the polls may or may not work for you. Professor Rea, I'm going to bring you back in. Hopefully you didn't start cheating on that lunch.
No, the lunch is being cooked by I have a very close friend who's a High Court judge, and he invited me for lunch at 2 o'clock. So I am slightly in trouble at the moment. I forgot. Anyhow, I've told him I have more important things to do. So there we are.
Quite right.
I'm obviously going to get the burnt leftovers. He's a fabulous cook.
So we're going to start off, Peter. I'm going to read out the first few questions to you. Some of them, I have to say, Peter has already answered in some of his presentations, some of these questions. And also during the presentation, Peter, there were a couple of supplementary questions that referred to things said, which I'll try and slip in as and when we can. So first question, let me get this to you from Rachel. She's been on the waiting list like many others for a balance issue with Meniere's and referred by an ENT consultant to a balance clinic at University Hospital, Coventry. Rachel thought they were going to help her with a balance and walking, but they instead only offered her an hearing aid. Unfortunately, she doesn't have any family support, but really needs to be independent. She was told by Coventry to go back to a GP to refer to Leicester, and she's done. My GP assessment said balance issue was due to Meniere's, nothing he could do, and she should try and exercise at home. She's lost muscle mass, and despite me saying to the doctor this is affecting my daily life, nothing's happening. She's very isolated, no family support. She wants to try and get out more. What can you offer any help and advice? Also, Professor, I just mentioned we've got Claire here, audiologist, that also at any time can fly in if she's got anything to add to these things. But over to you, Professor. What can we tell Rachel?
Firstly, thank you to Claire and Antonio. I enjoyed listening to your work as well. It's good to see there's so much going on. And for our patient, I'm really sorry to hear this. It's really sad to hear. And it really emphasizes the point I made about conditions like Meniere's disease that are multifaceted. So you can have vertigo attacks, hearing loss, tinnitus, imbalance, and a whole bunch of other stuff as a consequence of it. And each of them need addressing. Regarding coming over to Leicester, for a number of years, the hospital management have not allowed me to see people from outside the county because our waiting times are already a year and we're just totally overwhelmed. And you'll find that with sort of big successful centres in every specialty around the UK, like migraine clinics and other things, they close their doors. So if your Coventry referral was from this side of Coventry, i.e. towards Nuneaton or Hinckley, you might be able to get referred in. But if it wasn't, unfortunately, I can't get you. I'm not allowed to see you on the NHS. It's not my rule. I've fought it, but you know, the management have.
Peter, I can confirm it is Hinckley. So she's
well, if it's Hinckley, you've got a reasonable chance of getting in. So some of the GP practices can come into Leicester, and you just get your GP to write to me in person, but it's going to be a 12-month wait, I'm afraid. But we would certainly look at doing vestibular physiotherapy, seeing if there are ways we can manage your vertigo as well with maybe introducing panic steroids. There's a whole range of stuff. But firstly, we'd establish a diagnosis. So there is hope.
Yeah, just a quick question to Claire. Is there anything can be recommended to people waiting to see, such as Professor Rea, that they could do at home that may prevent muscle wasting and be of general use to them and do them no harm? Oh, you're on mute, Claire. We need to unmute.
Sorry, laptop's really old.
Thank you.
Sort of any form of exercise, as long as it's safe. You know, you can do exercises while you're seated. You know, you don't have to be standing up with the risk of falling to keep keep yourself going. Meniere's, I don't know if she's had a formal diagnosis for it, but usually once you've had some sort of surgery or you've had the treatment or it's burnt out, the VR will help. But whilst it's still so changey, it's quite hard for it to be effective. That's about all I've got for that one.
Okay, no, lovely. On to the next question, Professor Rea. This is from Jane. I have chronic vestibular migraine. I've tried all the treatments available on the Montfort Royal Migraine Specialist Pathway. I'm currently taking 5 milligrams of flunarizine Arazine. Apologies, I can never pronounce the drug names, but hopefully Professor Rea knows what I mean. Which is helping to manage my condition. It has enabled me to return to work and experience some of life's joys, which is great. Like going out for a quiet meal and watching film at the cinema. Keen to know if this drug can be taken in the long term.
Yeah, so flunarizine, it's actually not, it's unlicensed for this use in the UK. It is licensed abroad, but it's not licensed for use in the UK. As a general rule, a 6-month course is recommended. It's not a drug that I prescribe myself. That doesn't mean it's not a good drug. It's each of us has our own sort of list of drugs that we like to use, and it would be you just have to speak to whoever the neurologist or ENT who prescribed it. But as a general rule, it's a drug we don't give long term.
Super, thank you. Julia asks, I would like to know which balance disorders Professor Rea knows of that are progressive. Most I've come across have their ups and downs, such as vestibular migraine. Others stay much of the same or luckily improve. Despite my best efforts, my condition continues to deteriorate, and I'm wondering what could be the cause. CANVAS, C-A-N-V-S, has been mentioned as a long shot, and I have been referred to the team studying this. I'm therefore wondering what other conditions are known out there to be progressive.
Yeah. Okay, so I mean that's actually a great question. I mean the first thing I would do is just refer you to the talk I gave a year ago, because that had a lot of non-medical causes of dizziness. But if you want the commonest thing to answer your question, it's age. So as we get older, we lose muscle bulk, as our last patient has. We lose confidence, we lose proprioception, we lose vestibular function, we lose vision, we lose everything. So as we get older, generally our balance gets worse. CANVAS is rare. This is cerebellar ataxia, a shaky thing, bilateral vestibular failure and loss of sensation in the legs. Now, to diagnose that, there is actually a genetic test for CANVAS you can have to confirm it. It's a rare condition. There are a few bits on the scan, MRI scan you can see as well. But goodness, there's a massive list of conditions which cause progressive imbalance. And it can be as simple as sitting on your chair at home, deconditioning. That's very common. So you lose muscle bulk and confidence, through to progressive neuropathies, cerebellar ataxias. There are some specific cerebellar ones. CANVAS you mentioned we'd normally see with abnormal eye movements, and we could diagnose with a combination of clinical assessment and caloric testing, for example. But I mean, the list is just as long as your arm. I mean, I could talk all day on it. So you need to see someone who knows what they're talking about and is able to assess all the different causes of balance if you've got progressive worsening. And there's definitely a possibility with it that you'd have an underlying neurological or musculoskeletal disorder. Yeah.
Super, thank you. Jean asks, previously raised the issue of varifocal spectacles adding to vertigo problems. I think this was in a previous meeting, Peter. Does Professor Rea have a view on cataract surgery? Both of my eyes are affected. It seems surgeons are reluctant to do both eyes at once, but it's noted that for very short-sighted people, even without vertigo, the imbalance of vision if only one at a time is done, can cause extreme dizziness. I am -7 with astigmatism on an endless waiting list to see an ophthalmologist. I would really appreciate Professor Rea's view and any advice he could give.
Yeah, that's a very interesting question as well. It's slightly counterintuitive, particularly in older patients. You think giving them vision back would make their balance better, but actually for some patients it makes it worse, because they're now getting new visual input to balance. We do have some of our older patients who have cataracts done whose vision gets worse, and it's something you'll have to speak to your ophthalmologist. The ophthalmologists are usually pretty aware of this, and if you're younger, certainly one would be wanting to get it done. If your eyesight's very poor anyway, it seems like a sensible thing to do. But just be aware that for some people it can make the balance worse, certainly in short term.
Okay, lovely. Caroline asks, there don't seem to be any dedicated neuro-otology services available via the NHS. Instead, patients have to navigate simultaneous care pathways with ENT specialists and neurologists, which can be difficult. Why is this, and do you see a need for change?
No, that's not true. There's lots of neuro-otologists in the NHS. I'm one. So we have a lot of ENT surgeons who are specialist neuro-otologists, and we have audio-vestibular physicians who also have expertise across the spectrum. In fact, the audio-vestibular physicians have a medical background, so they even have a broader medical training than someone like me who trained as a surgeon. I agree with you that we need more. We've worked hard to get balance centres throughout the NHS in the UK. Finance is an issue. There are some regions that just don't have anyone, which is dreadful, but that's just how it is. There are some regions, many regions, that do have really good neuro-otologists, but it's difficult to access, and you've seen the reason why, because of the number of people who have it. But I get your point, and I agree with you. There are issues that if you come to a balance clinic like I run, hopefully I'll be able to get your diagnosis at the very least. But if the cause of your balance is, say, Parkinson's disease, which affects 1% of people over 75, or peripheral neuropathy, which affects over 5% of people over 75, I would then refer you to a neurologist because they have extra expertise in that. And if you're very elderly and you have falls and lots of other things, you might get referred to a falls clinic. So there is a need for expertise in other groups. The reason that they're not all run together, and we have tried it, is simply money. The cost of having a heart doctor, a neurologist, an ENT surgeon, etc., all sitting next to each other in the same clinic is just, it's impossible. So that's the reason.
Lovely. Claire, I'm going to ask you to take over reading the next question, please. And I'm just going to take a breather for a minute.
Okay.
Over to you.
The next one is from Sue. She says she's been wobbly again after 5 years in remission, but it doesn't say from what, unfortunately. Had a few dizzy attacks again, where she had to stop what she's doing, wait for everything to stop moving, and for the brain fog to lift. She says it usually happens when her asthma is bad and she's feeling congested, but also when she's not experienced any problems. To further complicate things, she's also got a cataract in her right eye, which she's hoping to be removed in the near future. She says her world feels very blurry, she's more miserable than usual, she's struggling to hear because she can't see people's faces, not that the hearing is bad, but obviously that visual input. Is there anything I need to tell the ophthalmologist prior to surgery, and what do I need to do afterwards?
Yeah, I mean, there's lots of potential causes for your balance worsening there. So your vision, we've talked about cataracts before. Dizziness when you're having an asthma attack, you often hyperventilate with an asthma attack, and hyperventilation is a very common cause of dizziness. If you're feeling low, that's another very common cause that can worsen dizziness. There's lots of potential causes there. Do you need to say anything to your ophthalmologist? Probably not. I mean, I think you need, if you get your cataract done, that's a good thing. Make sure you've seen an audiologist to make sure you've got hearing aids and your hearing is suitably amplified. And really, very much as Clara said before, get yourself out and make sure you're exercising, getting a good diet, sleeping properly, and I hope you feel a lot better with those treatments. I'm sure there is a sunny upland out there.
Okay, next question is from John, which thankfully is quite short. Any updates on the vestibular implant?
Yeah, no, that's still being worked on. We're not doing it in the UK at the moment. There's a group in the Netherlands who are working on doing some really good work out there. There's 3 groups around the world working on the vestibular implant. It has been implanted into some patients. It's still experimental. It's been much more difficult than anticipated. We're not trialing it in the UK at the moment, but I think that probably, I don't think it'll be that far off. I think it'll be the next few years. So it's definitely making progress. But there is an alternative, which you saw Kevin talking about there, which is the balance belt. So if you're looking at a vestibular implant, you've probably got bilateral vestibular failure. That's loss of balance function in both inner ears, head injury, gentamicin are common causes of that. Sometimes it just happens. And it's a belt you can wear that stimulates your body. And in fact, I've met the inventor over in Leicester, and we're having him come over on our big international course next month as well to demonstrate it. So that may be an alternative to vestibular implants. It's still early days, but we're very interested in it.
Good. Next question is from Vimla. In 2021, her ENT consultant diagnosed vestibulopathy, vision preference, and right-sided eye drops. She says her balance has worsened since she had the COVID vaccination. Her consultant has said it's possible that her inner ear balance mechanism was damaged after having measles as a child. She goes on to say the past few months her balance has been significantly affected, and be causing her a lot of anxiety. So much so she's finding it hard to do the balance exercises. Is there anything you could recommend for her to do? She's taken beta-histine for a few years, but are there any other medications she can take to help cope? So I think you've touched on some of that. But...
Yeah, again, there's a lot of bits there, a lot of speculative stuff there. So did mumps or measles as a child cause it? Can cause damage, which perhaps can cause hydrops. Hydrops being Meniere's disease later on. Can the COVID vaccine? There's quite a lot of people who think it might be, but the evidence again is fairly uncertain. COVID certainly has caused damage to the inner ear. There's no doubt about that. But the one thing that stands out to me there is you're having vestibular physiotherapy, and Claire touched on this earlier on, that if you have active Meniere's or you have hydrops, this fluid buildup that's active, it causes a fluctuating balance disorder. So the balance varies. Vestibular physiotherapy doesn't work if that's the case. You need to work from a fixed vestibular deficit. In other words, the hydrops not being active. So the first thing I would do in that setting is just make sure the hydrops is not active. That may involve intratympanic steroid injections, for example, rather than medicine, because medicine tends to suppress a problem rather than cure it. So I think maybe second opinion for you there.
Okay. Another one that I think you've already answered from Rebecca. How successful is a steroid injection for treating Meniere's?
If it's Meniere's, the average reduction in vertigo attacks over 2 years is 90%.
Excellent. Next one from Geraldine. She's been taking venlafaxine. That sound right?
Yeah, venlafaxine is SNRI antidepressant.
Microdose for a couple of years, but over the last 6 months have titrated up to 15 granules, and she thinks she's getting some benefit. She's increasing by 1 granule a week, aiming for 1 capsule, which is 37.5 milligrams. Is it safe to continue to take it at this dose when she's been on it for over 2 years, but mostly only at 2 granules? If she gets to the full dose of 37, much longer would it be safe to take that amount? Also, as a note, she's also taking 10 milligrams of amitriptyline for pain relief.
Okay, so that changes things. So just for venlafaxine, opening the capsule and taking granules, I do have a few patients who have said that's really effective. The normal starting dose is 37.5 milligrams, which is 1 capsule, and we titrate up to 150 milligrams. We normally recommend a 12-month course, but you need to be aware that the higher the dose you take, the more difficult it is to come off. Some people get brain zaps and find it a bit difficult coming off. You'll be okay, but it can be a bit more difficult. So for those patients who are hugely helped by it, I'm not uncomfortable in taking it longer. However, the slight googly here is the amitriptyline. There are plenty of people on low dose amitriptyline, say 10 milligrams in the evening, and a low dose of venlafaxine or an SSRI, but absolutely fine. What you've got to be careful of is that they both attack or affect serotonin function. So there is a rare condition called serotonin syndrome, which can be caused by taking amitriptyline plus venlafaxine or similar drugs. And so I think you just need to speak to your GP about that to make sure you understand it and make sure you understand the risks of taking both together. They're not very high, but you just need to be aware of what the risk is.
Next question is been submitted by Ali, but I think maybe on behalf of his wife, Lenny. It says, I have right-sided vestibular dysfunction. I'm having physio at, I think it's University College Hospital, vestibular clinic, but not improving. Every day the following happens. First, they get weak knees and feel as if they're going to collapse. Their head is cloudy, and then every afternoon, sort of between 4:30 and 6, something happens in their head. They start to sweat to the extent that the back of their neck is wet and cannot describe how bad and sick they feel. They also get loud tinnitus at the same time. Is there anything that can be done? Thank you.
Okay, well, that's a difficult question. I mean, you're at a good centre, so I think you'll probably have seen some good people down there. It's very difficult on those symptoms. I mean, there's a possibility that sort of anxiety, panic attacks are creeping in here, causing hyperventilation, sweating, jelly knees, and so on. But there are other potential explanations for that, and I think they'll be really difficult to answer just with that limited information set. And I think that would definitely be something just to discuss with your audiovestibular physician or ENT doctor to try and pull that together, because there's some other stuff that needs looking at there. Yeah, most likely it's not serious, but I think you need to inform your doctor of those, because it's an odd mix of symptoms.
Okay, question from Ruth. Could you tell her if head and sinus pressure can be a symptom of PPPD?
Yeah, for sure. and it's a classical symptom of migraine as well. So when people come to us with facial pain, they always say we have sinus disease, and very, very few do. The vast majority have essentially it's facial migraine. We call it atypical facial pain or myofascial pain, and it causes congestion and swelling of the nose and facial pain. And with PPPD, one of the things that happens is you tense up your muscles, so you get muscle tension throughout the head and neck. So we often get occipital neck pain, tension over the head, and you get facial tension and facial pain. So the answer to your question is yes.
Lovely. Claire, I'm going to let you have right. You're a natural at these questions. So we're definitely going to hear more from Claire in a little while. So back to me asking the questions, Peter.
I'm getting a hard time over here, Kevin. Sorry.
No, go. From Barbara. I have been diagnosed with Meniere's disease. However, every recurrence over the years has started with a sudden drop in hearing on one ear or the other, followed by months of other symptoms, vertigo, tinnitus, ear fullness, etc. I've never found a trigger. Could this be autoimmune? How can it be distinguished from Meniere's, and does it make any difference to treatment? I also have other autoimmune diseases, type 1 diabetes and hypothyroidism.
Yeah, if it's bilateral, the two things you think about, it most definitely could have an autoimmune trigger. That would be the first thing you think about with this. And the treatment, it's particularly sensitive to intratympanic steroids. So steroid injections tend to be particularly effective with this. The only other thing you'd need to think about is it migraine? It could be vestibular migraine because it's affecting both ears. So you'd need just to see how the inner ears are functioning, what the hearing is like during attack. It is a big drop, a small drop, but this could highly likely. But remember, autoimmune Meniere's is Meniere's. It's just a subgroup of Meniere's disease. That's a really interesting, it's a dangerous word, isn't it? That's a really interesting story, though.
One related question to that. We often in the group talk about the negativity of hypervigilance, of constantly monitoring every moment. I used to do it when I first had Meniere's. The second I gained consciousness, I was, am I dizzy? Am I not? Get out of bed. What's happening? What am I eating? Is it a full moon? What are the tides like? Everything and anything. Until I realized I was exhausting my mind every day and never found a trigger, apart from the obvious thing to do with salt. Never ever found a trigger that helped me in my entire life with Meniere's. Now, that's just me with Meniere's. In your experience, people coming to you with actually proven, scientifically tested triggers, does it happen? Does it help you? Or are we all fooling ourselves when we say we're looking for triggers? How is it for you?
No, it is. I mean, there's definite triggers for a lot of conditions. So, I mean, vestibular migraine and migraine are the ones where we have the really powerful triggers. But there's no doubt that people have triggers for Meniere's disease as well. And modifying life is a very important part of this. And it can be something as, it's extraordinary how some people live. So some people think that having 6-7 cups of coffee a day is a normal thing to do. Some people think that having a bottle of wine every night, because all their friends do, is a normal thing to do. Some people think having an hour and a half sleep in the afternoon but not going to bed to 2 o'clock is a normal thing to do. So, that's not normal. That's going to trigger a lot of illnesses. So a lot of what I do in clinic, I use the analogy of I'm holding a mirror up to your life.
Yes, yeah. And any general advice, how do we avoid being hypervigilant? How do we avoid?
Yeah, so what we do is that's why CBT is one of the main strands of treatment for many balance disorders. Certainly PPPD, migraine, it can be helpful, but for anyone with balance disorder, CBT, because you're human, that's the important thing. We're all human, and so these symptoms do get to us. Doesn't matter who you are, it gets to you. And so having someone support you with anxiety therapies, with CBT therapies, is really helpful. And we've got books which can help as well, a whole bunch of stuff.
Yeah, lovely. I'll put links in the chat, by the way, to some of our past meetings that have covered that area. Question from Simon: do vestibular illnesses get worse with age? As my body gets older, will I experience more frequent, more severe Meniere's or vestibular migraine episodes or clusters? Is there anything I can do to aid recovery post episode other than go back to basics on diet, physio, and listening to my body? So 2 questions there.
So I'll divide that into 2 halves. So chronic imbalance tends to get worse with age because we decondition, we lose muscle bulk, etc., 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 and we lose confidence, become fearful of falling. Episodic vertigo tends to get better with age, particularly in migraine. And we talked about having travel sickness as a child, maybe really bad headaches when you were a student, and then maybe if you're female, having bad attacks around your period, and then having a terrible time in your 40s when you're perimenopausal. And then I always talk of the sunny uplands of postmenopausal bliss, when often the migraine and migraine and vestibular migraine attacks disappear and life settles down. And actually, it's called the migraine march. It's the march through life. So yeah, a lot of vestibular disorders get better when you're older, except for the imbalanced ones, which get worse.
Okay, lovely, thank you. Gemma asks, diagnosed with acoustic neuroma last year, referred for vestibular therapy. However, I only saw the physio once, as he said, I don't present like others with vertigo. I didn't have the nystagmus, so he didn't know how to help. Does he think it's worth pursuing vestibular therapy for my balance issues? And would it need to be with a specialist in acoustic neuromas?
Yes and no. So yes, it's definitely worth pursuing vestibular physiotherapy. No, it does not need to be with a specialist in acoustic neuroma. It needs to be a specialist with vestibular physiotherapy, because with balance disorders, you wouldn't expect the therapist to see nystagmus. That would be very unusual. One point about vestibular schwannoma, however, is if it causes some degree of fluctuation in your balance, this fluctuating balance disorder rather than fixed balance disorder, sometimes giving gentamicin to the ear to destroy the balance function, paradoxically, will make you a bit worse in the short term, but can make you better in the long term. So you need to see an expert in that. But for most people, we can help very much.
Super, thanks. Claire asks, I would like to ask Professor Rea's opinion on how what we eat impacts on vestibular migraine. See a lot about heal your headache type diets. Others say keto is helpful. Lots of people seem to think migraine is triggered by various foods. What's the experience in relation to using diet to help manage?
Yeah, for sure. I refer you back to that slide I put in with the 6 C's. Diet's a very important part of migraine management. I think, and the best thing, because it's different. For some people it's lobsters, some people it's champagne. It's it can be tomatoes, it can be anything. So the best thing to do is keep a diary of everything you eat and drink, and relate that to the attacks, and hopefully you'll be able to find out. 'Cause it may not just be what you eat and drink. It may be lack of sleep. It may be arguments at work. Who knows what it is? So you need to try and find that trigger.
Super. Anonymous question here. Part 1. Is visual preference avoidable if you have bilateral vestibular hyperfunction?
Yeah, that's a difficult one, actually. It's a really interesting question. So this is where you lose balance function in both your inner ears. It's absolutely devastating. It's totally awful. It's where we talk about vestibular implants, which aren't available yet, or the balance belt, which might be of interest. We don't know yet. Yeah, I guess it is, if you look at it like that, because you've got to do, rather than doing adaptation exercises, which is what most vestibular physiotherapy is, you do substitution. So you try and substitute the lost balance in the ear with using your eyes and the sensory input. So I guess the answer to that is yes. Yeah.
Super. And then hopefully this means more to you than me. Is osteopsia just to be managed?
No, oscillopsia is when the world bounces up and down. So you walk and the horizon bounces up and down. You go over a bump in the car and the signpost bumps up and down. So it can be caused by a severe unilateral deficit, so severe labyrinthitis. It can be caused by bilateral vestibular failure. That's the classic one we see. And it can be caused by bad things going on inside your head. So you certainly need a brain scan if you have oscillopsia. We can help it with physiotherapy. We can sometimes help it with balance suppressants. But no, you absolutely need to try and treat that. Most people, we can help with it, unless it's severe bilateral vestibular failure or it's a brain thing.
Super, thanks. Len asks, since April, I've been trying many things to reduce my symptoms. I was diagnosed almost by accident with carotid artery defect in my left neck. As a result, I'm taking blood thinner, clopidogrel, and lansoprazole. Yeah. My symptoms are now the worst they've been in over 5 years, and I would appreciate your views on whether or not the artery problem could have been the cause of my symptoms all along, or whether the blood thinners could now be making the symptoms worse. Any thoughts on this are much appreciated.
Yeah, so it's not going to, the blood thinners will be saving you rather than making you worse. It's extremely unlikely they're the cause. The problem is, I don't know what your carotid artery lesion is, but if it's a carotid artery stenosis, a narrowing of it from atherosclerosis, from hardening of the artery, which is most likely, it's quite likely you've got something called cerebrovascular disease. So that is hardening of the arteries in the brain, and there's been really good work at Imperial particular showing that that can be associated with imbalance. That's one thing. And the second thing is, if you've got very tight stenosis, you can have problems with blood supply to the brain, particularly as you stretch your neck. That could potentially be treatable with carotid artery surgery, but it's far from without risk, and that's definitely something to speak to a vascular surgeon about. So not clopidogrel, but the artery could be causal. Yeah.
That's great. Claire, I'm going to pass over to you now. If you can carry on with the next question, please.
Hey, the next one is from Claire, not myself. Dealing with the word eek, which is always good. Just booked a flight to northern France, and I'm so nervous. For my vestibular migraine is pretty much cured. I'm still suffering with motion intolerance. My test flight going to Dublin was awful, and I felt everything so much more than everyone else. The thinking was like I was on a fairground ride that made me think a huge distance more than everyone else. Can you recommend some good vestibular suppressants that are better than the 2 milligrams of diazepam and the 10 milligrams of prochlorperazine that I took for Dublin?
Yeah, I mean, diazepam and Stemetil are perfectly reasonable ones. Stugaron, Cenarazine is the one we normally recommend, 30 milligrams. But try and think of it a bit more broadly. So keep yourself well hydrated. Don't have any alcohol or caffeine. Book into a business class lounge at the airport so you can go into a quiet corner. Try and get the sort of fast track, and so first boarding, so you're not standing in the queues. Take a blindfolded mask so your eyes are covered. Take some noise cancelling headphones, so the stress of the noise of a plane, and just sit quietly with a blindfold on and headphones on. Take your diazepam and Cenarazine, whatever, and that's the best way. And don't drive.
Okay, next few questions are all from Rachel, so I'm not going to keep introducing her again. First one, I have triple PD, and driving a short distance can set off a bad relapse of the dizziness that can take weeks to recover via rehab exercises. Do you suggest travel sickness medication to lessen any dizziness from travel in a car?
Yeah, there's no reason not to use it. You're clearly severely affected, and that's really unpleasant for you. But you can try and drive rather than be a passenger. If you're a passenger, again, you can put a blindfold on. Some people find that helpful, but Cenarazine is the one we would usually use. Yeah.
And again, so she's got triple PD and has once experienced BPPV at the same time, and it was horrific. Prior to having triple PD, she'd twice had dentist-induced BPPV whilst having drilling done. She now needs further work done. Can you give any tips on how to minimise the chance of getting, I like this, dentist-induced BPPV on top of the triple PD?
Yeah, so that's a really nice question, actually, because it really goes back to that bit I said, that triple PD's often got a condition like BPPV, a bit of an alphabet spaghetti, BPPV in the background. So vitamin D to see if you can reduce the risk of BPPV. But the main thing, and the dentists won't like this, is you just have to tell them you have to be propped up. It's not great for their back, but if they can lift their dental chair up and try and work with you propped up, that's what you have to ask them, and not tilting your head back.
Goes on to say, now an expert at rehab for the using of vestibular exercises, but is very susceptible to relapsing of the triple PD due to visual and sound sensitivities. He's currently housebound but can manage short walks and would like to get out more, but any kind of transport sets her off, as just going in a shop. Any helpful tips on how to get out gradually, hopefully causing minimal relapses?
Yeah, I mean, that's a difficult one, isn't it? But I mean, you're absolutely right. It's essential to get out, and just to find a time where it's quiet outside, it's not busy at the shops, and doing things you enjoy, maybe going for a walk in a quiet park or the woods, whatever it is that it gives you that pleasure and gives you stimulation and fitness. I'm working with a therapist like Claire, who can support you through that. That's the important thing. But the key is not to stay at home. It's a really long-term thing. There's lots and lots of bits to it, I'm afraid.
Next thing, whenever she gets an infection, she gets a relapse of the triple PD and post-viral fatigue on top of the bug, which altogether are pretty debilitating. Any way to help her avoid PPPD relapse and post-viral fatigue?
Again, it's really difficult here because you're overlapping with other conditions like chronic fatigue syndrome, ME, PPPD, functional neurological disorder. There's quite a big overlap here, and some of it's within my expertise, and some of it isn't. The problem is when you have balance disorders like PPPD, your body is on the edge already. So if you get jet lagged, you have a row with the boss, you get an intercurrent illness, you have a bad night's sleep, all of these things can worsen it. And minimizing that risk is a good thing to do. And taking the medicine, CBT, and treatment for PPPD is absolutely to be encouraged. But I don't have an easy answer to that, sorry.
She's heard that taking magnesium supplements can help. I think you touched on this before, definitely. Can you explain if this is true, and if so, what dose would be appropriate?
Sorry, I missed.
Check with her GP.
Sorry, taking what? I missed that. Sorry.
Magnesium.
Magnesium. Sorry. Yeah.
I think somebody asked in the chat
yeah,
as well.
No,
what sort of?
Yeah, no, magnesium. I'm a fan of magnesium. 400 milligrams daily. Just remember, one of the formulations is Epsom salt, so some people get slightly loose bowels afterwards. But or you could use Dolovant, which I put in there, which is 400 milligrams of magnesium plus I think it's 400 milligrams of riboflavin B2 plus coenzyme Q10, vitamin D. There's a range of other things. That's quite a useful one. It's quite expensive, but it's worth thinking.
Professor, sorry, just a minute. There was something in the chat earlier about which particular type of magnesium, because I believe there's lots of different.
Yeah, there are lots of different sorts. Just, I mean, read the labels. You can read them yourself to see which you prefer, because some of them might make you a bit squitty, some of them don't. I don't have a strong preference on them. Yeah.
Okay, thanks.
Next question's been submitted anonymously. What impact does the menstruation cycle have on the vestibular system for those with balance disorders? What changes in symptoms could be expected when female enters the perimenopause and beyond? Any suggested strategies to aid symptom management during this time?
Yeah, that's a good question. So massive is the answer, principally with vestibular migraine, but to a lesser extent with many of the other balance conditions. So and the perimenopausal especially. I talked about the migraine March a moment ago. So what we tend to do is think about, if everything else has failed, we think about hormonal manipulation. So it might be as simple as going on HRT or the pill. Some people find that good. Some people find it makes them worse. And you can speak with a gynecologist who can manipulate your hormones in a way that suits you. But it's very much trial and error. And then the last bit I mentioned is after the menopause is hopefully the sunny uplands, because really many of my ladies do get a lot better afterwards.
Yeah, and I think I would just add from sort of personal perspective and from at work, the way our symptoms already affect us all very differently.
Absolutely right.
It affects the symptoms, the balance very differently as well.
Absolutely right.
Okay. Next question from Bernadette. Do you have any advice about rescue medications for vestibular migraine attacks? She's tried many of the triptans and used them in conjunction with maximum dosages of paracetamol and ibuprofen. You're advised to take propylperazine, I'm so willing to say that, at the same time, but I discontinued it as it made my dizziness worse in the long term.
Yeah.
Currently taking, rimgapant?
It's a G-pant. Yeah.
Thank you.
So the triptans have been shown to be, I mean, they're great for migraine headaches, but they're not terribly good for vestibular migraine. The G-pants are the CGRP inhibitors, and they're the drugs that are being shown in maybe as many as 75% of patients to help with the vestibular migraine attacks. So really, once you're getting up to there, you've been through some pretty high-powered management, and there's not a whole bunch of stuff beyond that at the moment. But you sound like you've been well looked after.
The continuation from Bernadette. She has PPPD on top of the vestibular migraine and is struggling to make progress with the VR exercises, particularly the gaze stabilization, as doing them tends to trigger vestibular migraine attacks. She's currently taking, another one, Atoglipant. Yeah, sorry about this. For vestibular migraine, and they're under better control than they've ever been, but still chronic. Any suggestions on the way forward?
Yeah, I mean, you sound like you've got great. These are the GPAP, the CGRP inhibitors again. You sound like you've got a great team looking after you. I mean, vestibular physiotherapy and migraine, it can certainly make people feel rough. And if you're with a good consultant, stick with them. If you found someone you like, stick with them. But I think the key to vestibular physiotherapy with triple PD and migraine is very, very gentle. You do very little, and you don't push yourself too hard.
Super, thanks, Claire. I'm going to step back in, and we're trying to get you to that lovely
Yeah,
lunch.
my wife's actually just looked through the door and left without
Yes,
me, so I am now officially in the doghouse.
Right, we're going to move really quickly on this. Next question from Len. Vitamin D, you have mentioned this in a great deal on the slide, so he was asking whether it's going to work for him and for many people with balance conditions. He's got vestibular neuritis. Question is, any evidence, scientific studies that vitamin D works? Over to you very quickly.
Yeah, so it's really primarily, the scientific studies primarily with BPPV, not vestibular neuritis. But if you are vitamin D deficient, and in Leicester, a large proportion of our Asian population who are often veiled and often don't leave the house are severely vitamin D deficient. In that group of patients, they tend to respond very well because they get low mood, muscle ache, body ache, and fatigue. And vitamin D can make a big difference to that group. Some Caucasians also get vitamin D deficient. I mentioned wearing a lot of makeup or foundation can cause vitamin D deficiency. And I think everyone should be taking it over the winter anyway. But purely from a vestibular neuritis perspective, no, there's no data on that.
Okay, super. I've been on it for years.
You're on a big dose.
Yeah, really good. Right, really quickly. Next question from Joanna. I've had suspected many years, over 20 years, with hearing loss, ear fullness, tinnitus, vertigo attacks. My last vertigo attack 5 years ago was very severe. It took me 3 months to recover, left me with impaired balance. I suspected the diet played part in the attack, and due to fear of another attack, I've restricted my diet, particularly reducing the amount of MSG, yeast, sugar, histamine. I no longer use ibuprofen. I haven't had an attack since. This may, however, be due to my age, 59. I'm aware that vertigo can become inactive in Meniere's. Is he aware of how diet can play a part in Meniere's type conditions?
Yeah, for sure. So diet can definitely cause, particularly with low salt, with salt is the one we talk about most. And the second point from your question is that Meniere's does burn out. It might take a year or it might take 40 years, but eventually it generally burns out. Yeah.
Yeah. So
diet's important.
Yeah. From Anna, is it worth trying nerve blockers or Botox for vestibular migraines?
It's more commonly used for migraine on its own, not vestibular migraine, but some people have trialed it. The evidence is not strong, but I have no problem if you want to trial it. Yeah.
Okay. I think this next one you've probably covered, but quickly from Dina. Regarding the treatment of vestibular migraine, in addition to medications such as nortriptyline, what supplements would be advisable to take? Vitamin D, vitamin B2, magnesium.
Magnesium, B2, and coenzyme Q10.
Yeah, brilliant. Recommended. And next one from Diane. Since last September last year, I've had balance issues make me feel almost drunk. An MRI in February showed I'd had a stroke. Over these months, my balance worsened, particularly whilst I was taking prescribed beta-histamines, which I had to stop taking. My left peripheral vision differs from my right. Things coming from that side often startle me. My neurology consultant thinks it's triple PD. Could the stroke have caused left-sided vision changes and potentially triggered the triple PD? In the meantime, while I'm still waiting for an ENT consultation, are there any steps I can take to help manage these symptoms?
So yes, I mean, a stroke can certainly cause visual loss, and can it trigger anything can trigger triple PD, but you have to work out, is this a central disorder, i.e., is it caused by the stroke, or is it a information processing disorder, triple PD? That's really difficult to say, but it could be both. Can you do anything in the meantime? Not really, because we don't know what the cause is at the moment. You have to get that diagnosis, sorry.
Okay, no worries. From Faye, I'd like to know if it's possible to have vestibular migraine without getting headaches, as I don't get them.
Absolutely. 10% of migraine attacks occur without headaches.
Okay, my symptoms of imbalance generally made worse by visual stimuli, lights, movement, tracking, etc. Busy, noisy, overstimulating environments. The audiologists say the visual element is typical of migraine, and I understand I can prescribe migraine medication without either the calorie test, which I'm reluctant to do, or completing the 16-week vestibular rehab. I've had a clear MI of my ears and waiting for another one to look at my brain. I have nystagmus, which has been recorded.
Okay, so yeah, I mean, certainly, with the answer is yes. I mean, I think 16 weeks of vestibular physiotherapy is a fairly short period. We would say it'll take 3 months to show any recovery, but it can take up to 12 to 18 months to get maximal recovery. And if you've got vestibular migraine, you know, there's a good reason not to have a caloric test. You can sometimes feel pretty rough on them with that. Yeah.
Super. Nearly there. Sorry, nearly there, Peter. Fay, but a different Fay. I've had vestibular migraine for 4 years. Worst symptom for me is floaty, disconnected feeling. It's now 70% better to what it used to be. What can I try to continue to see improvements? Are there any new medications I can try? I'm currently on blood thinners. Does that limit my treatment?
Yeah, I mean, I think that if you're on blood thinners, I mean, I've given you a list of medicines which can be helpful in the talk there, but you have to speak to your neurologist because there's definitely interactions. You've got to be careful.
From Sandy, dear Professor, a long while ago I asked you a question in the past meeting and you said to me, I had a spinning brain. I'm diagnosed with vestibular neuritis migraine. How is it that I can dance for hours at a dance party, but I cannot walk in a straight line?
Yeah, that's a very interesting question. A lot of our patients with vestibular disorder can ski, can cycle, and it really depends on what the stimulus is for you. So some people it's a vestibular stimulus, some people it's a visual stimulus. So for example, some people when they're dancing and skiing, they can keep their head still and steady doing it. Whereas in other things, you can have something very simple, just going into a shop, and the visual stimuli is too much. So it depends which stimulus it is that affects your balance. So that's a really good point, because it's really unfair on so many people where their bosses say at work, well, you're fine, you can do this, that, and the other. Why can't you sit at the computer? So thank you for that. That's an important point to share.
Lovely. Question from Ian. Could Professor Rea discuss the relationship between triple PD and fatigue? I appreciate individuals vary a lot, but my own triple PD seems linked to fatigue, but I'm uncertain if fatigue is aggravating my triple PD or if the triple PD is causing or aggravating my fatigue, or maybe both.
Yeah, no, it's chicken and egg or egg and chicken, isn't it? So the answer is yes and yes. I mean, it can certainly work both ways.
Very good. Last question, Caroline. I've recently moved back from living in Thailand. The neurologist doctor I was under didn't know very much about my condition, which had been diagnosed in Australia as BPPV. My balance has got so much worse and I need to walk with a walker. However, in the last few months, I'm suffering more with headaches. Could these be migraines? How would I know the difference?
But the answer, I suppose, simple answer is yeah, it could be migraines. But if you're needing a walker now, you need a proper assessment. So it could be anything we've discussed today, anything we discussed last year. And you know, you've got to confirm you actually have BPPV. I never trust what people have been diagnosed before. I've always got to start from scratch. So you need to see someone with that. Yeah.
Lovely. Professor Rea, thank you so much
Great
for
pleasure.
today.
Lovely to see you all.
Apologies to overrun by 10 minutes. Apologies to some members who had supplementary questions, and there were some late ones in today. We just have run out of time, but we are going to see more of Professor Rea. Hopefully.
Of course.
Christmas special will hopefully get Peter back. Thank you also, Claire, Antonio, Wendy. Thanks to all of you for attending. Remember, without you, we don't have a group. This is your group. The group is you. But thanks, everyone. You're all allowed to come off mute now and cheer and applaud for the world's greatest balance expert, Professor Rea.
Yay!
Thank you very much. We'll see you all in
Kevin,
as well.
8 weeks. Watch out for your emails. Thanks, everyone.
Enjoy the good weather, everyone. I'm going to go and have lunch. Bye.
Enjoy. Bye. Thanks very much, everyone. Bye-bye.
Bye.